Hello, everyone, and welcome to today's Ask the Expert event, Understanding Hospice Care. I'm Ashley Laporte, and I'll be your host for this important and heartfelt conversation. Thank you so much for joining us. Today, we'll be talking openly and honestly about hospice care, what it is, what it isn't, and why it matters. Our goal is to help you feel more comfortable and confident if and when hospice becomes a part of your loved one's journey. We're joined today by three incredible panelists who bring deep expertise and compassion to this work. Dr. Grace Huffman, Medical Director of Mary Washington Hospice, Amy Hoffman, Director of Mary Washington Hospice, and Mary Bevan, Community Bereavement Liaison with Mary Washington Grief Support Services. We'll start with talking with our expert panel and then open the floor to your questions toward the end. Feel free to submit questions in the chat at any time. Let's begin by clarifying some common misunderstandings. Dr. Huffman, can you help us define what hospice care truly is, and perhaps more importantly, what it is not?
Sure. Thank you, Ashley. I appreciate the chance to be here today. I would say that hospice care is specialized medical care for patients with a terminal illness, and it's designed to support and comfort that patient and their loved ones, whoever they consider their circle. And it might be helpful to define that a little bit further because that probably just raises more questions. Specialized medical care means that, for example, I'm a physician who is board certified in family medicine and geriatrics and hospice and palliative medicine. So, hospice and palliative medicine is a medical specialty. We're all familiar with cardiologists who take care of hearts and dermatologists who care for the skin. A hospice and palliative medicine specialist is someone who cares for not an organ system or a particular disease, but for a patient who is at a certain point in their life. Just like a pediatrician cares for children at the beginning of life, we care for patients at the end of life. The phrase terminal illness probably needs more definition because we're all thinking, well, I don't come with an expiration date stamped on me. And that is true. So hospice is very regulated. And one of the hospice regulations says that a hospice physician and your physician, whoever, if you have one, need to certify that they think you have 6 months or less to live. Now, it raises another question of how would you know that? And it is very difficult to predict when someone will die for the most part. But there are various indicators we look at. So that's how we determine if someone is thought to be terminally ill. And if the terminal illness doesn't the death doesn't occur in that 6 month time frame, that's okay. Patients can stay on hospice for much longer than that. And while they're on hospice, this is the third part of what I said, is we're trying to provide comfort for patients and families. And that comfort is, of course, trying to address physical symptoms, whatever may be occurring and bothering the patient, but we're also trying to address spiritual and emotional and social suffering that may come up as people get close to the end of their life. So I would say in a short nutshell, that's what hospice is. What hospice is not is it's not a place. People often think that they need to move from their home to another building, a hospice building. And for some hospices, they do have freestanding hospice buildings, but many do not. So it's not a particular place. And in fact, I'm familiar with hospices where they have cared for patients who didn't have any sort of stable home. So hospice tries to meet people where they are, literally, when at all possible. Hospice does not provide around the clock care. So we're not coming in providing the care for you or your loved ones. We're trying to support the caregivers who are already providing that care. And we're not an organization that hastens death. That is not the goal of hospice. And maybe we'll talk about that more later. And we're also not about giving up. Hospice is not about giving up at all. It's about helping people to live their fullest life for as long as they have. So people will often say, well, my doctor told me there's nothing more they can do. And I would say that we in hospice and palliative medicine would say, well, that's just when we're getting started. We're trying to support and treat symptoms and provide the emotional, relational support that people need when they're getting close to the end of their lives.
Thank you, Dr. Hauptman. That was a wonderful answer and a great oversight over what hospice is and what it isn't. Amy,
Yeah.
you work closely with patients and families every day. What do you often hear that surprises people about hospice?
Um, I think one of the biggest things that surprise people is that we have nurses available 24 hours a day, 7 days a week, and they don't think that, they can call at any time. You can call us at 2 in the morning, 3 in the morning. We're going to answer the phone and we're going to either help support you over the phone or our nurses are going to come out and make a visit. Um, I think that's one of the biggest things. We have such a great team of nurses, social workers, chaplains, aides, volunteers, bereavement support. Um, our providers that are on, they're on with us too. If it's a medication question at 2 or 3 in the morning, we can always reach out to our provider that's on call. So we always are available 24 hours a day, 7 days a week. I think that's one of the biggest things that we get most of all. Like they'll call like when their office opens, well, I didn't want to call and bother you. Well, you're not bothering us because that's what we're here for. We're here for you. So it's one of the biggest
That's
things.
That's a wonderful support, I'm sure, for families to know that they have somewhere to go or somewhere to call when those questions come up. Because I know inevitably the important questions never come up between 9 and 5. They're always at 2 o'clock in the morning when you're like, what do I do?
Yep. And you're at
And
your wit's
having
end.
Yes, exactly, and having someone
Yeah.
to call is
Yeah.
a really a huge comfort.
Yeah.
Mary, from the grief support side of things, what do families tell you that they wish they'd known sooner?
The biggest thing I'd say is people wishing that they had come on to hospice services earlier on. We get a lot of people who are very close to the end of their life, maybe even within hours or days, and you really aren't experiencing kind of the full benefits of hospice when your time with us is so short. And by that, I mean kind of what Amy was speaking to about the support from the nursing team to provide education about what's happening with your loved one, the support of the social worker or the chaplain to provide that spiritual and emotional support, and then to utilize our awesome volunteers and our CNAs. It's just a really robust team, and to be able to access the full benefit of that, you need more time. And the benefit of that really is that you have a more clear understanding about what is happening in this process, which can sometimes be scary or overwhelming. So to have the support, and we do our best to be there, and to, like Amy said, be available 24/7. But a lot of times when you're in those really high emotional situations, like when your loved one is very ill, it can be hard to hear that information kind of all at one time. So by being in hospice for longer, it allows for people to hear those conversations in kind of bite-sized pieces over time from multiple team members, which really gives peace of mind to the caregivers, and to the patients who, also might be wrestling with some of these really tough end of life experiences. The second thing is just kind of, like I said, utilizing that whole team. So, some people can be resistant to talking to the social worker or the chaplain. Many times people have unfortunately had negative experiences with one or either of those, groups of people in the past, or just kind of misconceptions about what it is that social workers and chaplains provide. So I'd say the thing is that when people allow the whole team to come and participate, it just provides more peace of mind, and more trust, and more people that you can kind of process this experience with, and really be. I guess the thing is, we talk about peace, which is a really kind of a tricky thing because most of us maybe won't feel peace when somebody that we love and care for is dying. So we're not having peace necessarily that the person is dying, but can you have peace about the way that their care is going, the support that you have, maybe having some tough conversations, that, those are the things that are going to give you peace of mind, that the circumstances, the setting of the death, is filled with peace.
That's wonderful insight, Mary. Thank you. I think it's really important for people to understand is that hospice provides so much support and resources and a whole team of people to come around you so that you don't have to experience this alone.
Yeah, that's it
Ashley,
exactly.
I'm sorry.
Go
Can
ahead.
I tag on to what Mary said first about getting hospice involved sooner rather than later? Just to provide a data point, the hospice benefit is looking at someone being on hospice for 6 months, or as I said, maybe more, but 6 months are about 180 days. And the average length of stay that patients are on hospice nationwide, last I checked, 17 days. So people could be getting 10 times more benefit or more time with hospice, which allows us to get to know you and your family and your loved one and what's important to you and help support that.
That's a great point, Dr. Huffman, that um, you should not wait to get on hospice service until the very, 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 very end. It's more of a shift from curative treatment to hospice care and support. And we'll talk more about that later, but excellent, excellent point. Let's turn now to some of the most frequently asked questions that you guys see in your practice. Uh, Amy, can you walk us through what a family can expect when someone begins hospice care?
So normally when someone begins hospice care, a referral will come in from their doctor, or they can refer themselves. Like they don't have to have that doctor referral. We will reach out to their physician to see what's going on and make sure they're appropriate. And then we will talk with Dr. Hoffman and get her expertise on, what diagnosis to use, what's their actual terminal diagnosis for hospice. And then we will set up a time for the admission nurse to come out. And the admission nurse will come out usually within 24 hours. We really do work very hard to, as soon as we get that referral, to get the team out there. Um, and sometimes they'll come out with the admission nurse and the medical social worker will both come to the admission and do the assessment, talk to the family, make sure they understand hospice and what kind of care that we provide. It's very important for the patient to understand and their family or caregiver who's going to be with them and know the kind of support that they need and that we can give. We get some DME, maybe a hospital bed, bedside table, oxygen, medications that they need, um, usually within that same day, if not within 24 hours, depending on what's going on and what the patient needs. And then with that, they'll get calls from the chaplain. Another great thing that we have here, because we are a non-for-profit, is yes, we look at insurance, but you do not have to have insurance to come on to our hospice. We take people without insurances a lot, and that's okay. Um, we still give you the same support as we would give anybody else, whether you're private pay, insurance, no insurance. It's the same support. Another great thing that we have that I'm very proud of is we have a music therapist and massage therapist that come and to the home or facility or wherever you're residing that you're getting the care for hospice, and it's just that extra added support, comfort, and they do a fabulous, fabulous job.
Yeah, that's a really amazing perk that our hospice offers that not all hospices do is we have those supportive therapies. And Amy, I wanted to ask you to clarify, you kind of touched on it a little bit, but when you say
Mhm.
that the nurse comes out to admit, where are they coming out to? Can a patient receive hospice wherever their home is, or is it?
Wherever their home is. So whether they're in their home, their sister's home, their brother's home, in an assisted living facility, in a nursing facility, wherever their home is. We've had people in motels because that's where they're living, that's where they're residing. So we really do try to build it for the care that they need of where they're residing at the time of they're on our services.
Yeah, I think that's a great point because I know that's a common misconception is that people aren't aware that hospice can come out to wherever you call home.
Yep.
Dr. Huffman, Amy kind of touched on this a little bit, but I want to ask you, who pays for hospice care?
This might be more of an Amy question, but uh, hospice care is typically called the Medicare hospice benefit, which does not mean you need to have Medicare to be on hospice by any means.
Exactly. Right.
So other insurances tend to sort of dovetail with what Medicare is doing. So that hospice benefit, as Amy said, is what's paying for all the medications related to whatever your terminal diagnosis is, paying for the durable medical equipment like the bed or the shower chair or whatever might be needed, pays for all of the staff salaries. So there's not typically an out-of-pocket cost for hospice. There might be a very small copay for some insurances. I'm not quite sure about that, but hospice is really an amazing benefit that covers an awful lot, and it covers those therapists, and it covers the social work, and it covers um, post-death bereavement care, or grief, not counseling, but
Yeah.
bereavement care for
Yeah.
a year or 13 months after someone
13 months.
died. Yeah. So it's really sort of an all-inclusive benefit.
Yeah,
Did I
that's
leave out
really,
things, Amy? Sorry.
No.
she got it all.
Yeah.
Good, good, good. Um, Amy, when we're talking about hospice care, I know that you know, healthcare sometimes isn't linear. A disease progression doesn't always follow the projected path. So sometimes a person with a terminal illness could improve, they could decline, they could improve
Yeah.
again. So tell us, can
Yeah.
someone leave hospice care and then come back later?
Yes. We have people that graduate all the time. And they graduate because they become either very stable, or they have gotten better, or they've left the area. And then maybe 2 or 3 months go by and they're starting to decline again or change, and they can come back on services. So that's the beautiful thing about hospice is, you may be able, you may come on services, get admitted, 4, 6, 7 months down the line, things are really looking better, and you get what we call discharge, because you may be no longer hospice appropriate, and that's okay, because nobody has an end date on them to
We don't
say,
have crystal balls. We don't
no,
have
we
crystal
don't.
balls in
No, my crystal
healthcare.
ball's been broken for 27 years that I've been on hospice, been a hospice nurse. So yeah, so no, we don't have crystal balls, and people can come on and come off and come on and come on. That's they're called benefit periods. But yeah, there's no, if you get discharged, does not mean you cannot come back on service. You can always come back on service if you qualify for what the regulations that we have, because it is, like Dr. Hoffman said, it is very regulated.
I would also
That's
chime in with another misconception about hospice, which is that
Sure.
after that 6 months, then you have to be discharged. And Dr. Huffman did touch on that earlier. There isn't a limit on how long you can be in hospice. You just have to still continue to meet the qualifications and the criteria that Dr. Huffman was talking about,
Yeah.
to kind of qualify to stay on hospice services. But it's not like on the 6 month day you get kicked out, or we say, okay, tough luck, bye. That we continue to provide services as long as they're appropriate.
Yeah.
And one more way that people can get out, we don't see this very often, but you can choose to not be on hospice anymore. You're not held captive. And if you feel that you're not benefiting from receiving the support services, or for whatever reason, or you decide to pursue more aggressive care if something's suddenly available to you, that's fine too. And then if you need to come back on hospice in the future, when you are thought to have a 6 month or less prognosis, that's absolutely fine.
that's great clarification for our viewers out there, and really important information to have. We've touched on a lot so far on the support for patients, but one of the beautiful things about hospice, in my opinion, having had family members on hospice and watched the support that my family received, is the support that's given to family caregivers. So, Dr. Huffman, I'd like to ask, and Mary and Amy, please chime in if you have more to add, but how does the hospice team support caregivers specifically?
Well, I think there's a variety of ways. It might be something as what we would consider simple as treating a symptom, treating pain or nausea or shortness of breath, and that can provide a lot of relief for the caregivers because they're not stressed and anxious about not knowing what to do. We provide a lot of education for those caregivers so that they understand the medications and how they're to be used. And we're certainly, as I think Amy said, willing to provide that over and over because it's hard to take in all of this new information. So just ongoing education, because we have so much experience with people who are at the end of life, we sort of know what to look out for. So we can describe what that roadmap might look like for families. And that, I think the biggest thing I see is that reduces their anxiety a great deal, to just know what to expect and to have somebody who can say, yeah, this is normal. That doesn't look like how people normally breathe, but
Right.
for someone who's at the end of their life, this is normal. And that's very reassuring, I think, to
Yeah. And just telling someone like it's okay. Like what you're seeing is natural. It is part of the dying process and it's okay. And we're going to be here with you through this.
I'd say a really big issue that we observe in our families is caregiver burnout. Some families, this has been a really recent diagnosis and it's kind of been a whirlwind but for some people, they've been caring for their loved one for 10, 12 plus years and they're exhausted. They love their person and they, do their best and provide really excellent care, but it takes its toll. So that's one of the things that the team works on, and I'd say especially from the social work perspective, is finding ways to help the caregiver get some relief. That could be getting volunteer services set up so that the person can get out for a couple hours to have lunch with a friend or run some errands, whatever. It could be getting, working with the family to get hired caregivers in place, possibly having the family apply for Medicaid. There's a variety of ways. That's just a small sampling. But really to give that caregiver some relief. And honestly, just having, again, all this, the whole team, it doesn't matter which member of the team is in the home, but to really spend time. And that's something I really love about the hospice model and the hospice philosophy is that unlike other care settings, we really are able to spend time with our families and with our patients and be able to listen to their concerns and be able to, kind of try to come up
And
with some
and
solutions.
families.
Yeah,
Yeah.
yeah,
Yeah.
exactly.
And it might be something as simple as starting an aid,
Yeah,
to
exactly.
help with bathing once a week, just to give them that break.
Right.
Yeah, that's great. Great information. I feel like yes, the patient is the focus of hospice, but it's not the sole focus. It's really the goal is to be really supportive for the family because while the patient may be dying, it's an experience for the entire family and the caregiver and having that support, having someone to talk to about it. Just my own personal experience with hospice and watching my family member go through that. Having someone to talk to about it was a huge help. And like you said, saying this is normal, this is what it's supposed to look like. It's a
Okay.
scary thing for humans. We don't like to face our own mortality. We don't like to watch it happen. So it's a really good thing to have experts around you who can tell you this is fine, this is normal, this is what's supposed to happen. Um, Amy, you've talked about this a little bit, but I want to go a little bit more in depth about what is included in hospice. So we talked about durable medical equipment, which is referred to as DME, supplies, emotional support, like what is actually included in the hospice benefit?
So what is included in the hospice benefit is you have we are we have a let me go back. We have nursing support 24 hours a day, 7 days a week. Whether it's phone call, making visits, we have chaplain support. Um, our medical social workers make visits to the homes. Our aid support. We can provide durable medical equipment as you need it, whether it's a hospital bed, oxygen, um, bedside table, bedside commode, those things, medications that are related to the terminal diagnosis. So it may be pain medicine, maybe anti-anxiety medicine, constipation medicine. So all those medicines, we kind of make sure that you have what you need. So when it's 3 in the morning and you have a symptom that comes up, you have the medicines there ready to use, whether it's morphine, lorazepam, all any kind of medicine you can have. Um, we make sure that you have what you need. We
And
also go ahead.
no, go ahead.
Okay. Um, we also have the volunteers who can come out that can help. Um, they usually will sit with the patient if the family member has to go, to their doctor or or just sit with the patient and do, it may be, they may be working on a legacy thing to leave for their family, or we have our veteran volunteers that go out and they do veteran pinnings for our patients that are that have served in the military, any branch of the military. We do veterans pinnings, and they get a pinning and a certificate. Um, and they're really excellent. Excellent. We've got an excellent volunteer staff that does that. Plus, we also have volunteers that have dogs you know, for our people that love animals, that, they can get that extra support too, just to love on a dog for a little while. So,
Oh yeah, the therapy dogs are special.
yes, they
We
are.
love, and their handlers. We love their handlers too, but
Yes,
the therapy
yes,
dogs are a beautiful thing.
yes, yes. So there's a lot of things that come in play. And I think one of the greatest things that hospice is because we're in your home, and there's such intimacy there between the nurse and the family and the patient, and you really get to know them. And hospice is able to follow for 13 months with bereavement. And that's something that's really special in itself, to kind of get you through all the holidays for that 1 year that you lost your loved one, and it's 13 months because it gets you that extra month. So it gets you through that annual, time of when the patient did pass, and make sure that you're doing okay. And we have great bereavement support here.
Yeah, absolutely. There's so many resources. It's such a holistic approach
Yeah.
to this process that I really
Yes.
appreciate.
Yes.
Um, So, Amy, you mentioned some medications, and
Yes.
we're here today to ask the hard-hitting questions and the things that
Yep.
people want to know. So, Dr. Huffman, I want to ask, and I want you to talk a little bit about the way that hospice views medications and pain medications, and whether they are ever used um, to hasten death or used in any manner other than pain management.
Well, let me start out by saying I liked Amy's overview of all these, and what I was thinking when she was talking about all the services that are available, and including, in our case, music therapy and massage therapy. I was thinking that
Mhm.
those services, volunteer, social worker, nursing, everything, those can all help patients have their pain and their anxiety reduced without using medications. So I would say that excuse me, the best way to try to manage symptoms is to use a multidisciplinary approach. So it's not just giving medications to people, but yes, absolutely. I'll say morphine is the medication that people often object to and are worried about. And absolutely, we all read the headlines about opioid or narcotic, as people will call them, opioid overdoses. And I think this goes back to my talking about having specialized care in the hospice, specialized experienced care, because we have no intention of overdosing people with medications. We're experienced at using the medications. And yes, morphine is not a drug to be taken lightly. Morphine and its siblings are sort of very similar drugs like fentanyl and oxycodone, hydrocodone, hydromorphone. These are all serious drugs, but when used appropriately for symptoms such as pain, then and escalated if needed to control that pain, I think they're known to be extremely safe and are very good at relieving pain. The other thing that opioids are very good at is treating shortness of breath, which is another common symptom that we see, whether someone has lung disease or not. There are many symptoms that are common to whatever is the illness that might take your life. So whether someone has cardiac disease or pulmonary disease or dementia or cancer, all of those conditions can have these certain symptoms at the end of life. And pain and shortness of breath are among those. So morphine and its siblings, it's a very good way to treat those. But we use them, I would say, appropriately and judiciously and carefully. I see it sort of like we might have a scalpel is a very, very, very sharp knife. It's not just like what you get out of your kitchen drawer. And we might not want to use that for certain things, but a trained surgeon would have to use a scalpel. So I think to me, that's sort of an analogy that works in that you want people who have the training and the skill and the experience and the expertise to use these medications. So we don't use them cavalierly, but we try to tailor them to what someone's actual problem is so that we can help them achieve comfort as they're going through the dying process.
I think that that's beautifully said, that the goal is comfort, not, moving anything along or anything like that.
Right.
Um,
But we do recognize that all of these medications, whether for pain or shortness of breath or anxiety or nausea, most of those medications we use do cause some sedation. And for some classes of medication, the sedation doesn't wear away. Your body doesn't build up a tolerance to it. For opioids, your body typically, if you've been on it for a period of time, days to a week or so, your body will build up a tolerance. So if you're seeing your loved one being very sedated, even by a very small dose of an opioid, that usually won't last. They will build up a tolerance to it. And so people worry about that, and they think that we're just over sedating people. And again, that's not the goal. So we're trying to be very judicious about
That's very well put. Thank you. In that same sort of vein, we've had some questions in the chat about food and drink at the end of life and how hospice
Okay.
handles have food and drink. So, can you, Amy or Dr. Huffman, can you share what hospice's philosophy
Sure.
is on that?
Sure. So, our culture is you want to feed people. Somebody's sick, you want to feed them. As patients start to decline and change, their body needs less fluids, less food, because their body doesn't need that anymore. It's transitioning, it's changing, it's starting the dying process. And when that patient starts those changes, you'll see that they're not eating as much, they're not drinking as much because they don't need that anymore. What they need is you to be present. They need your love, they need your care. And it's hard to watch somebody die. I mean, I've watched my mother die on hospice. I truly do understand that this is not something easy and taken lightly. Um, but the patients really don't need that, because when you start either forcing them or highly encouraging them, all you're going to make more symptoms. You're going to make them nauseous or sick, or we have patients that the family wants to do IV fluids and stuff. Well, it puts the body in what we call fluid overload that can cause pneumonia, edema, things that they don't need, because what happens is their body doesn't know how to handle it, because the body is slowly shutting down. The body is changing. um, and just having the nurse there to say, this is okay, it's normal, this is part of the dying process. To me, it's important for somebody to say it's okay.
and
Yeah.
it's also uh, we don't restrict people. Like Amy said, we don't necessarily force people to eat,
Right.
but we wouldn't restrict someone. So if there's someone who has followed, for example, a you know no concentrated sweets diabetic diet for years and years and years, and they've been very diligent about that, there may come a time where they want to take a milkshake or something, and we might say, well, we would allow what we would call pleasure feeds. As long as it's safe for them to swallow, we would say, at this point in your life,
Yeah.
we can allow that. But
Okay.
that's a discussion we would have with the patient, family, and with the whole team, sort of making sure that everybody's on the same page to allow patients to have the support and to get what they want at the end of life as much as
Right.
possible.
Yeah, I can really appreciate that, because because I want a milkshake, guys. Just so you know, I want a milkshake when the time comes. I completely I love that philosophy of hospice that the pleasure feeds and really, it's all about comfort. As we've said over and over again, it's about making the patient's final days as comfortable and as pain-free, and as good of a process as it can be. That's what these trained professionals are here to do. Um, so we kind of want to talk a little bit more about hospice as a philosophy of care. And as a side note, I see the questions in the chat, and we do have a section dedicated to those questions. So be assured we will get to your questions. Um, but back to hospice as a philosophy of care. Um, Dr. Huffman, I'd love to hear about your perspective as a physician, how you talk with patients and families about this shift, because when we're coming onto hospice services, we're shifting from curative care, which curative care means you're seeking a cure, you're continuing to treat. From curative care to comfort care, which is what we're talking about here, where we want people to be comfortable, but we're not necessarily trying to cure their disease process any longer. So how do you have those conversations? What kinds of things do you say to them?
Well, the way I think about all medical care, regardless of whether it's hospice care or, whatever any of us go to the doctor for, I always think that there's three things that we're trying to achieve. We're trying to live longer, we're trying to be as functional as possible or be able to do for ourselves, or we're trying to be comfortable and or we're trying to be comfortable. So a silly example I sometimes use is if you break your leg, you're skiing or you're doing something active and you break your leg, well, you're probably in pain, so you want to be comfortable. You want to be able to have that broken leg fixed, maybe a cast put on or whatever, so that you could regain your function and go skiing again. And you don't want to get an infection. Say you had a terrible break and you're likely to get an infection. You don't want something like that to be what shortens your life. So you want to live as long as possible. And that seems to me just very simple. No matter what treatment you're going to the doctor for, it's trying to achieve all three of those if possible. But at some point, your doctor may say, we don't have anything else we can do to fix your heart disease or your lung disease or your cancer. There are no more surgeries. There's no chemos. They may have gotten to that point. So in that case, maybe living as long as possible is no longer on the table. So maybe then you're left with choosing, well, do I want to have as much function as possible? Again, that's a laudable goal. We all want that. Or do I want to focus on comfort? And what that might look like would be choosing between, do I want to try to do several hours of therapy every day, or do I want to focus on comfort? And again, ideally, it would be both. But in some cases, say, take a patient who has very advanced dementia, and we can't restore that function through therapy, through anything. We don't have a way to cure that dementia. And so then you might be left with two of the other choices, being comfortable or living as long as possible. And yes, going back and forth to the hospital and having tests and treatments and being in a hospital bed in a noisy environment, noisier than maybe your home, that is absolutely possible, and that could make you live longer. But it comes down to choosing how you want to spend your time. How do you want to spend your time? How do you want to spend your energy? And there aren't right or wrong answers, in my opinion. I think, again, hospice is designed to support people who have said, I would rather be comfortable than live as long as possible. Or I would rather be comfortable in what is probably my last few months than trying to go to do therapy at a rehab center. There's not a right or wrong answer, but hospice is specifically designed to support comfort and people who have reached that stage. And like I said before, it doesn't mean that you can't say, I thought I wanted comfort, but now I'm thinking maybe I have enough energy to go do rehab. I'm going to sign myself off of hospice. And that's fine. But it's important to understand that hospice is for people who have chosen to focus on comfort.
That's a really great way to put it. The analogy of the broken leg is really insightful because it really takes away the emotion of the dying process and kind of shows like these are just the realities of being human. This is what you can achieve. You can achieve comfort, or you can, try to live as long as possible. I love the way you said that. Um, so we talk a lot about how hospice is here to provide comfort, and we also say, hospice is here to help people live as fully and as peacefully as possible. Dr. Huffman, you mentioned, going back and forth to the hospital with the beeping and the monitoring and the pricking and getting your blood drawn and all these things. It's very invasive, which is worth it if you're trying to live as long as possible. But if you're trying to have comfort, maybe not so much. So, Mary, I'd love to hear from you how hospice helps people live as fully and as peacefully as possible, even in those final months or weeks.
Yeah, absolutely. I think Dr. Huffman said about kind of this individualistic approach, right? We kind of take each patient and family and speak to them about what's important to them, because that looks different to all of us. We all have different goals that we maybe want to achieve by the end of our lives. Maybe there's things that were left unsaid or undone. Maybe we feel like we have done everything we needed to do. We just want to be quiet and sit in our recliner and not be bugged. So that really is going to look different to everybody. But I think of kind of something that I have tried to do with families throughout my work as a hospice social worker. And even now in my role with grief support services, is something that we call life review. And basically, it's this idea of like looking back on one's life and all those important milestones, the birth of your children or an important career milestone, an exciting adventure you went on, whatever those things are, but spending time remembering and reflecting on those things. Now, many of our patients are at a phase in their disease process where they're not able to speak. But we always try to kind of share with that person, whether it's looking at pictures on the wall and saying like, hey, dad, remember this, or hey, your daughter Sally told me that you served in the Vietnam War and thank you for your service, whatever it is, right? But we're looking back and we're reminding the person of these things that they have done and achieved in their life. So I think that to me is one of the most special things about working in hospice, is that we get to share and learn about these families. And everything they've done. Another thing that we do to try to kind of create this peaceful environment is creating space for difficult conversations. Maybe there is a relationship that needs to be resolved, and the team can help to facilitate that conversation. Maybe the person who's dying needs to get something off their chest, and the social worker or chaplain can be a listening ear. So, like I said, this really is a very person specific question. But I think that it is an important one. And then also thinking about education, that, we've touched on this a lot throughout these 45 minutes together, that the idea of understanding what your loved one is going through can be really, really important, because it can be really scary. For many people, I'd say probably most, this is the first time they've watched somebody die. And so to be able to be there to support them, to provide that education is really, really important. I also want to just put a little plug in. Part of the Medicare hospice benefit is what's called a travel contract. So we have patients all the time who, travel to New York to visit their cousin one last time. They go to the beach to, feel the sea breeze on their face and touch the sand. So that's something that we can help facilitate, give it enough time, and again, kind of circumstance dependent. But I think that's really a way that provides that hope. Dr. Huffman said that when we first started, this is not meant to take away somebody's hope. This is a shift in the mindset of kind of what are we focusing on now and how do we find this kind of quality of life based on our current circumstances. And that's really what the team is there to help you do, is to figure out what that looks like for you and your family, and then how can we make it happen.
That's really beautiful, Mary. Thank you. I did not know that about the hospice travel benefit. That's a beautiful thing. Um, and that kind of goes nicely into my next question for Amy, which is really love to hear some examples of what you've seen and how early enrollment in hospice can make a real difference. It sounds like, Mary, you're talking about this travel opportunity, this travel benefit. With enough time, you could make that happen. And so that is clearly a benefit of early enrollment in hospice. But
Yeah.
Amy, can you tell us what else you've seen?
So when we have longevity in hospice, they really get the full team approach and that support. When we have patients on for 24, 48 hours, you might only see a nurse. You might never get a social worker or a chaplain, volunteer, aide, so the longer we have you, the more support you give, the more care we can provide to your loved one, the more support the family can get. And we really get to know you and what is going on and really cater to the individual patient of their need. Um, it's hard when we get a patient that is only on service for 24 to 48 hours. Pretty much we're in there. Either we're trying to treat symptoms, making sure they're comfortable, getting everything they need, and everything's just like rush, 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 rush. And it really doesn't give the family enough time to wrap their head around exactly what is happening. I don't know if it was Mary or Dr. Hoffman that said, for the family to have that understanding of what's happening, what medicines to give, how do we give them, how often do we give them, just trying to understand this is probably the first time that they've ever had anybody die, and understanding that now I've got this person who's dying that I love in my house in a hospital bed, and how do I even care for this patient, how do I care for this person, and reminding them that it is a person and they had a life and they had a past and they had a history, so the longer you are on our services, it's just better support for the patient, better support for the family and the caregiver, of what we truly do provide.
And can I give an example of a patient
Sure.
that, I feel like I'll always remember her. She had very advanced lung disease. So she was extremely short of breath and progressively short of breath. And she had been a gardener. This was spring. And so this was very likely going to be her last spring. And because she was on hospice service long enough, and we got to know her and know what was important to her, which was tending her flowers, growing her flowers. And she simply couldn't do it because she was so short of breath. She could barely get outside, and she certainly couldn't kneel down in the dirt, dig and weed and all the things that you have to do. And she was depressed because of that. And I'll admit, as a physician, I do tend to think of medications, and it's like, well, should we change or add or increase her antidepressant? But as the team, hospice is certainly a team approach. As we talked about her, we realized that the thing that was making her depressed was that she couldn't garden. And so we enlisted some volunteers to build her a raised garden, a raised bed on wheels. So they built some contraption that was on wheels that could be pulled up right to, where the window or the door where she was able to get to. And she was able to sit in her wheelchair and garden that last spring. And I thought that was just such a great example of how hospice can work together if we know enough about you as the patient, you as the family. We can try to brainstorm ways as a team to help make those last moments as good as possible.
Yeah. And not only that, also if there's children in the home, because there are a lot of times we'll get younger patients that have children in the homes, um, to really how can we support them? We have different workbooks and coloring books and stuff that we utilize for them to kind of grasp and understand what's going on. Of course, there's different age levels and different things you do, and with maybe a 4-year-old versus a 14-year-old, and also helping the either the parent or the grandparent, because we see a lot of grandparents as caring for their child who may be dying, and that child that's dying has kids, so they have their grandchildren there in the homes, and helping them understand, well, this age level is kind of here, and Mary can probably talk more about that, but really helping support the children too, because we can't forget about them, because they're seeing it all and they're taking it all in, so we really can't forget about the children in these homes too.
Yeah, that's an excellent point, and those are great examples of the ways that hospice can really, maximize someone's time and really make it very personal and meaningful. I mean, what a special memory for her family and everyone to have, that she was able to do that at the end of her life. Like that's so beautiful. Um, Mary, you lead our community bereavement services, which is an amazing program that I cannot rave enough about. But can you share a little bit about what that support looks like, both during hospice care and then after that loss?
Absolutely, love to. So I'll start with during hospice. So that time frame, we usually refer to for the family member, and actually oftentimes for the patient too, as anticipatory grief. So you're anticipating that the death is going to happen. It hasn't happened yet, but you're still beginning that grieving process. You're still likely feeling sad, or anxious, or angry. There's a variety of feelings, and all feelings are okay, and no feeling is right or wrong. But that support while the person is in hospice is really through the hospice medical social worker and the chaplain. And really, again, we're a team approach. So any person that steps foot in the home really is going to be engaging with the family member. About these things likely. But really the social worker and the chaplain are the kind of focused team members who address this. And they'll begin to process these things, give space for the family to talk about the challenges of caregiving and what life is going to be like after this person dies. Then the family member who was the family members of the patient are entitled to 13 months of bereavement services through the hospice that they were served by. So obviously we're here talking about Mary Washington Hospice. So our grief counselor would establish a connection with the family member, and then the two of them determine how frequently they want the bereavement contact. For some families, they're okay just getting letters in the mail, with kind of grief information. Some people though want that connection, and want somebody to speak to, so they would determine with the grief counselor the frequency of those calls, whether they were monthly or every 3 months or whatever. Again, kind of person and situation dependent. Um, in that time frame, though, after 3 months have passed from the death, we now, through Grief Support Services, have our grief support groups. So, for example, the loss of a spouse group met this morning, and those groups are open to anybody who was served by Mary Washington Hospice, but they're also open to the broader community. They are free; they're offered at no cost, but registration is required. So if you're interested in participating in any of those groups, we have for loss of a spouse, loss of a parent, and then we'll have our family expressions group, which is a family who a parent or sibling has passed away, and it is a family group. So the adult and the children come together for the group, and I can give more information to anybody who's interested in that. But those groups are really a time for connection, to be with other people who can understand what you're going through, time to share feelings, which can sometimes be uncomfortable, and to kind of hear other people's experiences about ways that they've kind of started to move forward and really process the death. So the care really is kind of goes hand in hand. Some people have experienced a loss that was really sudden. They didn't have the benefit of the hospice experience like we've been explaining. But the grief support is still available. And just like I said, we do require registration, and that you wait, about 3 months after the loss to participate in the group. But come my way. I'd love to get you connected or offer you some other resources if the groups might not be a good fit for you.
That's amazing, Mary. Thank you for sharing that. That's an incredible resource that we offer the community, and as Mary said, free of charge. You just have to register. So it's really important work that you're doing. So I'm going to open this question up to all three of you, but tell me what resources, if we have families who are watching today who are just beginning to think about hospice, what resources are available to them? What are their next steps? What are your recommendations?
Well, I'll tell you that I actually hadn't really ever been to the Mary Washington Hospice website. So I was curious what it is like. It is actually a really great resource. So it has information about what hospice services are, how you can qualify, how you can get in touch to get a referral, to make a referral for hospice. And it also has, this is my plug for advanced directives. It has a tab that explains what advanced directives are, which really is your healthcare wishes or what you would or would not want if you had an advanced illness. And it's really important to have those completed so that you can be clear about what you would and what wouldn't want, and you can let your family members and friends, whoever is involved in your care, let them know what your healthcare wishes are. So I would recommend that people start there and kind of check out the website and look through there and see. And then I'll just put separately a plug for the Grief Support Services website, which also has information about grief and some more information about our group. So I would just say go to the Mary Washington website as your starting point.
Yeah, and you can always call the office. That number's on the website, and just ask questions. It's okay. Like, no question is off off limits, really. I mean, because how are you going to know? You've got to ask. Um, so call the office and ask. It's okay.
And we also at times will do what I would call an informational visit. So a nurse might go out perhaps after I've reviewed medical records that can be sent over by your physician's office. A nurse might come out and sit down with you and do an evaluation to see if that person would be eligible for hospice, because the nurses are very good at determining who is eligible and would communicate with me. So, we're happy to do an informational visit if your loved one is determined not to be eligible for hospice at this point. Then we could give you some ideas of what to look for, things to look for that might make you eligible, so that you and your doctor could re-refer the patient to us at a more appropriate time.
That's that's all great advice. I love that. And Mary, I love what you said about the advanced directives. I think that's the best gift that you could give your family, is having a really clear understanding of what your wishes are. I think a lot of times with hospice, especially, a lot of the decision making, the angst that you have over making decisions for your loved one who can't make them for yourself anymore, is really difficult, because you just, maybe the patient's not in a place where they can tell you what they want. So it's really a peaceful thing to know someone's wishes beforehand. Then, like I said, it's the greatest gift that you could give your family, is to have that all laid out before you get to that point. Um, so now we'll take some time to answer your questions. Keep them coming in the chat. We'll get to as many as we can. But we do have several questions here in the chat. So some of these questions I think we've kind of touched on. We talked about, water and food, and how, our opinions are on that. Um, we have a question about dignity. So if a bedridden patient complains about having to wear items of clothing like undergarments or long pants, but the family insists that the dignity requires wearing them, what is hospice's philosophy on that? Are we going with patient's wishes, or are we going with family's wishes? What are your thoughts on that?
So I'll take this one. We usually go with what the patient wants, and find out the reason why, whether they want to wear pants or not pants. Is it comfort? Is it tight on them? What are the reasons behind it? And then kind of talking with the caregiver or family and explaining, this is why or why not they want to do this or not do this. But we always try to maintain dignity when we're giving care, when we're bathing. You know, we always try to maintain their dignity.
Excellent. I love to hear that. We do have a question about end of life doulas. Do we work with any local end of life doulas?
No, we don't at
No.
this time.
Okay.
Not that we're not open to it, but no, we don't work with any end of life doulas.
Okay. Let's see. We have some viewers who have some concerns that hospice is used to euthanize patients who are not terminally ill. I think we've talked about that in depth, but is there anything else that you ladies would like to say about that misconception?
It's probably worth an entire hour on its own, at least an
Yeah.
hour on its own. I would say we do not euthanize people. We do not hasten death. we don't like death any more than anyone else does. So we're not trying to speed it up. We're trying to make the whole process as comfortable as it can be. Death is not easy, just like birth is not easy. And so we're trying to uh, relieve some of the suffering, again, whether it's physical, emotional, spiritual, social, some of the suffering that comes around death. But we do not speed it up. We do not assist someone who wants their death speeded up. That's not our goal. That's not our role at all.
Yeah, absolutely. That's a great way to put that. Um, Dr. Huffman, we have someone in here giving you kudos. They appreciate that you said that other efforts should be taken before for pain before opioids. You mentioned massage, music therapy, things like that. She asks, do you explain the drug effects and your plan to give the patient their consent so the patient can give their consent? She had an experience where her mother was given some medications against her verbal wishes. She was not a patient of Mary Washington Hospice, is my understanding. Um, and she wants to know what the process is for obtaining consent for those medications.
So
That's
like
a great.
it
Oh, go
is.
ahead,
Go ahead.
Amy. So that's a great question, but go ahead, Amy. Let me think about that for a second.
Yeah. Okay. So I know, when I was a case manager out in the field and discussing with families, we're going to start this new medication, whether let's say it was, MS Contin, which is a long acting pain medication, explaining to them, what it's for, why it's given. I mean, I've had patients flat out refuse. They don't want to take it. And you know what? That's okay, because we're going to find something else that's going to help that pain. We have patients that just want to be in pain. I don't know why, but that's their right. That's their right to choose how they want to live. We all have the right to make our own decisions. We never force anybody to take them. That would, I mean, I don't think that would be right on any level at all. Just saying this is what you got and sorry about your luck. No, you always need to explain to the patient and the family, like, so we're going to start this medication and what the effects are going to be. Probably for the first 12 to 24 hours, they're probably going to be a little bit more drowsy because this is a new medication that they're having. But that should get better every day. So usually between after 24 to 48 hours, they'll probably be back to their normal self. They might be tired for that first 24 hours. This is a new medication, just like anything else. When you first go to the gym today on day one, usually day two, you're done. Like, I never want to go to the gym again. But you keep going and it gets easier and easier and easier. And that's kind of how I explain it. True. That's kind of how I explain, when you're giving the first, medication of a long acting medication. That's, but never to say, no, this is what you have and you can't have anything else. That would be not ethical on many levels.
I agree with Amy. I can't even imagine forcing someone to take a medication. Um, I am a big believer in explaining what medications are going to do. Like I talked about a roadmap of what's going to happen when people die. I think we should explain what we're expecting this medication to do, how long we expect it to last, how long we expect side effects to last. What are those side effects going to be? What are we going to do if we see those side effects?
Yeah.
One example is that when you take opioids, your body will build up a tolerance, as I mentioned, to various side effects, whether they make you nauseated or sedated or just sleepy or loopy or groggy, confused. But the one side effect that your body will never get used to if you take opioids is they will make you constipated. So we try to be very proactive about treating the symptoms that we can treat, and then giving sort of that tincture of time for other side effects to wear off. But we try to work with people as far as consent. Like I would think of that meaning like a written consent. I don't think we do anything like that, but we try to explain and educate and acknowledge that people are taking in a lot of information and we might have to explain things several times. It's not familiar to people. And I don't think it's fair to just tell people, well, we're going to start morphine now, or we're going to start whatever medication for anxiety now. We have to explain to them because we're trying to partner with the patient, not dictate to the patient.
I'll say on the grief side, And I'm kind of tossing this question back to Amy and Dr. Huffman. What I hear a lot from families is that maybe the person wasn't taking any of these kind of comfort medications maybe earlier on. And so now they're in that last phase of their life. They're in, hours to days. Maybe you could speak a little bit to why those medications might be started at that time when a person, like the patient themselves, isn't able to say, well, I'm having pain, I can't breathe, whatever. Where, what you're explaining of having like a conversation about it, they're not able to do. Because I think in my experience of listening to bereaved people, this is something that feels really sensitive to them, is that they like all of a sudden, well, let's give them this medication or that medication. So maybe just speak briefly about like why those medications might be initiated at the very end of life.
So at the very end of life, when let's say a nurse is making a visit and they're seeing a patient that's facial grimacing and they just don't look comfortable. They can't tell you what's going on, but there's signs and symptoms of facial grimacing. It may be guarding, it may be holding their head. It may be that change of breathing where there may be, their breathing has gone from like relaxed, like, and they can't seem to, they're just not at peace. They're not at rest. Um, Explaining to the family what's happening, like, yes, these are natural things that are happening as the patient is dying, but if we start this medication, or let's say if we start morphine or Ativan or lorazepam, or whatever, just to help keep the patient calm, so they're not grimacing, they don't have that frown on their head. It really is taking that extra step when you're in the home to truly explain what you're seeing and why these medicines are going to help.
Yeah. So I just
So
want to say, oh, go ahead, Dr. Huffman.
Finish your thought, Mary.
Okay. Just kind of to say it plainly that like the person's body was already dying and that these medications are alleviating symptoms. They're not hastening the death. That they're kind of
correct.
you're managing the symptoms rather than accelerating a process that's
Right.
already in motion.
Exactly.
It's a great way to put it.
Yep.
Um, we have a question about someone who said their client graduated repeatedly, which I'm assuming means graduated from hospice repeatedly and recently
Yeah.
came back in, mentally very clear, but physically declining slowly. They said they do not seem ready to transition. What tips or suggestions to aid the transition process? I'm assuming that to mean transition in like back into hospice services, but if I'm reading that incorrectly, let me know.
Well, I
So
would
it's
say, go ahead,
go
Amy.
ahead. It sounds like, so they've probably were on services, they probably were no longer hospice appropriate, went back on services, so they trying to transition them back onto services. Is that
That's my understanding.
okay?
We,
It's
we,
it's j-
just to clarify, we in hospice often use the word transition to mean someone is transitioning into the active dying process. So that's why it's a little confusing.
yeah,
Okay. Okay. Well,
yeah.
maybe I'm reading that incorrectly then. Does not seem ready to transition. What tips or suggestions to aid the transition process? So, I mean, maybe if the person who asked that question could maybe clarify for us so that we can really get to the meat of what you're asking, I would appreciate that because I'm not quite clear what you mean
Yeah,
there.
and I'm not either, and I don't want to say the wrong thing and then it's
Yeah, I'm with you.
totally wrong.
So we'll give you a minute to put it in the chat and let us
Mhm.
know, clarify for us. We have another question about whether we consider ourselves a pro-life hospice, which again, not clear what that means, but do you have any thoughts on that?
I haven't heard that term necessarily in relation to hospice, but
Yeah.
I guess I would say
Yes.
yes, in the
Yes.
sense that our goal is to help people live their life fully until their last breath and then to care for their family after. So when I think about pro-life, I think about kind of caring for the whole person throughout their life, right?
Right.
And I would say yes, we are that. That
Yes.
we want to help people live fully and to support the patient and the family throughout this whole phase of their life.
Yeah. I totally agree.
I totally agree too.
Another question, there are some concerns that hospitals push patients to hospice because of too many admissions and to make more money and things like that. Can you maybe answer that with kind of going back to how regulated this industry, like hospice is, and how many um, boxes you have to check to be hospice appropriate? Can you talk about that, Amy or Dr. Huffman?
Yeah, go ahead, Dr. Hoffman.
So number one, I can't even imagine a not-for-profit hospice like Mary Washington Hospice making money. We do not make money as far as I know. As far as the regulations, so when someone is admitted to hospice, I or one of my colleagues, one of my medical colleagues, would be reviewing that record to make sure they were eligible. At the beginning of care, I need to write up about every single patient that we admit. I need to write up a summary, basically, uh, of why I think they're eligible for medical care. And that's pulling from their labs and their hospital records, talking to family and getting more information from the patient, whatever source it is. So I'm trying to synthesize all of that. Uh, there's the 6 month period. So once in the middle of the 6 month period, I do that again to make sure that patient is still, even though they've only been on hospice for 3 months, to make sure that they're still thought to have a limited life expectancy. And after someone passes that 6 month period, I write a summary of every single patient every other month. I mean, they're staggered, of course, but depending on when they were admitted. So every 2 months, every patient will have a summary of why I still think that they are eligible. Or if they're not eligible, then as Amy mentioned, we would discharge them for having stabilized. We graduate them as it were. Um, so there's that. We're not keeping people on service. We can't keep people on service because we have the regulatory side rails, I guess we would say, guardrails of somebody looking at what we're doing and saying, well, this person really isn't eligible, so you can't keep them in service.
And I also think thinking about the question and like getting discharged, putting everybody on hospice. I wish everybody would come on hospice. That would help us, so much. But as far as the hospital's concerned, when they do make a consult to hospice, we really do. I mean, we get lots of consults every day. Um, and maybe it seems like they're pushing everybody to hospice, but we also have guidelines that we have to follow that we can't take every single case, but we can talk to every single patient and every single consult at the hospital. We try to go into the room, give them a kind of a snapshot of what hospice is and an understanding of what we may or may not do. But you also knowing that you can't stay at the hospital indefinitely, like nobody can. It's not an option. They don't have the capacity at the hospital or any hospital at that point anywhere to keep people indefinitely there.
I think
So it's
too,
it's a hard conversation.
yeah, and I think the reason this misconception comes up is because one of the kind of triggers, if you want to call it that, for when this conversation might happen about hospice is if somebody is having a lot of hospitalizations. Are they going in because they're really short of breath and they've been in 5 times this month? Well, that might be an indication that it might be time to consider something else. Maybe they have dementia and they've had a lot of falls. So sometimes that can be a reason to think about hospice if you're having a lot of hospitalizations, kind of a trigger point that you can say, okay, well, let's just start this conversation. And in the same vein, we don't want people to be continuing what could be futile treatment if there is this other option and the family might not know about it. The patient might not know that, hey, I'm at a point in my disease process where the hospice would be beneficial. So
Right.
what we try to do is intervene, whether that's the palliative care team or the hospice team, or the hospitalist, whoever it is who you're seeing in the hospital, to try to start those conversations as another option, as you are at this point in your disease process. So the goal isn't to push everybody out the door and have them, go over to hospice. The point is to make sure that people know where they are in their disease process and that these services are available almost always at no cost if you're
Yep.
being covered by your insurance.
Yep.
Yeah, that's one of the really important and fantastic things about Mary Washington Hospice and Mary Washington Healthcare in general is that we're a not-for-profit healthcare system and a nonprofit hospice. So making money doesn't really factor into the equation, the Mary Washington Hospice is here to provide comfort and help people. Dr. Hoffman, did you have something to add?
I was just going to say, in defense of my medical colleagues, it's very difficult to predict how long someone has. Like I mentioned at the very beginning, we use a whole variety of indicators, but I think if you've had a physician who's been caring for you for a long time, there's actually studies showing that that doctor is going to be worse at predicting when you are likely to die or how long you have left to live than someone who doesn't maybe know you as well, which seems a little odd even to me. But so it's difficult, and so sometimes physicians and your healthcare team will come sort of right up to that. This is often why we get late referrals. Referrals of people who only are on the hospice for a few days or a couple of weeks, is because maybe your physician didn't realize that. So we do try to do education with um, other members of the healthcare team, at the hospital or wherever in the community, at physicians' offices, to say these are things that you can be looking out for. Is someone having unintentional weight loss? Is someone uh, not able to function as well? That maybe now they're having more trouble getting dressed, or they're having trouble getting out the door, and so they're losing their function, and or they're having more symptoms. One thing I always think of is patients who maybe are very short of breath. Maybe they have advanced heart disease, and they really can no longer walk to the end of their driveway and get their mail because they're so short of breath. But they might not even realize that themselves. They might be sending their grandchild out to get the mail, and training their grandchild to be helpful, and they don't even realize that they have stopped exerting themselves at all. You just don't realize it. And so I think there's things like that. There's questions that we can ask that can drill down and help other medical providers sort of drill down, like, well, these are things that we see when someone is getting close to the end, and have you been seeing that in your patient? There is a phrase in medicine. I don't know how, I know it's widely known in hospice and palliative care, but called the surprise question. And it's, would you be surprised if your patient was dead within the year? And if the answer to that is no, I wouldn't be surprised, then that actually correlates fairly well with whether someone is uh, getting towards the end of their life. So we're trying to do education about that too, and not have it be a shock to a family that's suddenly told they need to be on hospice, because that's not really fair to anyone.
Thank you, Dr. Huffman. That's great insight. We are coming to the end of our time. I have one more question from our Q&A, and then we're going to wrap up. There's a question about our policy, Mary Washington Hospice's policy on time limits that we can spend with family and patients. So I know you've mentioned there's 24/7 nursing care and things like that, but that doesn't necessarily mean that a nurse or a social worker or a massage therapist is in the home 24/7. So can you talk a little bit about what the length of time a visit actually looks like and what people can expect?
So the length of time really varies on the patient and what the patient needs at the time. I spent anywhere from 30 to 45 minutes in a home to hours in a home, depending on if I showed up at the patient's house and they're having all kinds of symptoms, and I've got to call the doctor and we've got to change medicines. And I'm not leaving that house until I know the patient is comfortable and the family's comfortable with the medications they give. So, regular visit might be 45 minutes to an hour. A symptom management visit might be 2 to 3 hours, depending on what's going on with the patient. And that's for the nursing visit. Social worker is the same. Sometimes a social worker visit might be 30, 45 minutes. Another time, if they're helping with caregiving or there's stuff going on, it might be a couple hours. Aid visits are usually 45 minutes to an hour or longer. It really truly depends on what's going on with the patient and the needs. And I will say, as our patients start to decline, if they come on, they might be getting once a week. As they start to decline, it might go to twice a week. The visits might go to daily, depending on the need of the patient.
That's very, very clarifying. Thank you, Amy. Appreciate
Mhm.
that. Um, I want to thank all of you for being here today. We've had a really great and robust conversation, I think, about what hospice is and what it isn't. We've answered some great questions from our viewers. And we really want to thank all of you for being with us today. We hope that this conversation helped clarify the role of hospice and shown how compassionate care can truly make a difference. If you have more questions or you would like to connect with someone from the Mary Washington Hospice or Grief Support Services teams, please visit hospice.mwhc.com or you can call 540-741-3580. Please don't hesitate to reach out. We have an amazing team who's here to answer any questions you may have. But we want to thank you again for being here and take good care.
Thanks.